wonderful time again for the Puscast podcast to review the infectious disease literature with commentary for the first 2 weeks of January in the year 2007. Happy New Year. For those of you who are sick of this intro, like you, Dr. Jones, just skip ahead to the next chapter on your iPod. Brought to you, as always, by Puswell, LLC, the publisher of the Puscast annotated compendium of infectious disease facts, dogma, and opinion, your Uber hyperlinked electronic guide to infectious disease at Pusware.com. All the opinions of those of Mark Crislip, MD, and Puswell, LLC, and not those of Legacy Health System, its employees, the IDSA, the IDSO, the AMA, or anybody else with a brain in their head. Now CME accredited. Listen, take the online quiz and get a half an hour CME for free. Thank you, Legacy Health System. To mention any conflicts of interest, I have not talked to a drug rep or accepted anything from a drug company in almost 20 years, so all the biases are my own. See nofreelunch.org for details. Not that my honor and integrity are not for sale. I just expect a lot of zeros after the one. The purpose of this podcast is to review the literature of the last several weeks and, with commentary, declaim and pontificate of those articles that are of interest to me and hopefully to you. It is not a comprehensive review. I want to get to the point, so I favor breadth over depth and cheap shots over seriousness. Keeping up in medicine is a lot like drinking from a fire hydrant, to quote Dr. Richard Bryant. This is my sip and is aimed at the practicing healthcare professional and the occasional deranged amateur. I am, if you are interested, a practicing infectious disease doc in Portland, Oregon. I do this to help teach the residents in our medicine program. A good one if you are looking to become an internist. Try legacyhealth.org. Help me learn and, most importantly, advertise the aforementioned guide. But as Gag Hellfront said of another, I'm just this guy, you know. As a warning, it is not called Persiflagers for nothing. The podcast will contain snide comments, sarcastic asides, and short rants on political and other contemporary issues. Don't complain I didn't warn you in advance. Also, I have been called an arrogant subspecialist who does not appreciate the limitations of primary care. There, you're warned. If you like this sort of nonsense, may I also suggest the Quackcast at quackcast.com. Available through iTunes, where I review various aspects of scams, that's supplemental, complementary, and alternative medicines. Now, on to the literature. All references are online, and you can get them from your iTunes window on your computer to be taken directly to the reference. I usually don't talk about mathematical modeling studies because they are not of much clinical interest as a rule. However, there was an interesting one published in Emerging Infectious Diseases that looked at the effect of preventing transfused patients from subsequently donating their blood in an attempt to prevent the spread of Jakob-Creutzfeldt disease, i.e. prion disease and dementia. England has a large problem with this due to their mad cow issue. I think this is proven with their current Prime Minister's relentless support of our president. But they've had about 160 cases of variant Jakob-Creutzfeldt disease, and because of this, they have stopped patients who have had a transfusion from subsequently donating blood because of several cases where that might have been the way that the prion was spread. In this mathematical model, they figure that at best, if you exclude prior donors of blood from transmitting the virus by transfusions, you will probably prevent about 2 cases total. Given the crying need for blood most of the time, it's probably not a realistic or rational policy to prohibit patients who have had a transfusion from giving subsequent blood. And this was a study that assumed, amongst other things, that the infectivity of the prion was the same during the entire time that the patient was infected. Not a probably realistic assumption, but they made their model based on worst case scenario of infectivity of prion disease. I mentioned this study to, 1, make a swipe at our president, and 2, to point out that the spread of prion disease through transfusions is probably extremely rare. Also, when I was a medical student, it was called Jakob-Creutzfeldt disease. Now, for some reason, it's called Creutzfeldt-Jakob disease. When did the names get transposed? Anybody know? Let me know. And why would it happen? I can't find out. So you have an AIDS patient who's been put on their initial heart with a protease-based regimen. They've been non-adherent with their compliance or non-compliant with their adherence and have broken through. What do you do? What do you do? Well, in a study that was published in the Clinics of Infectious Disease, they compared patients who were switched to nevirapine, abacavir, or efavirenz-containing regimens and found that those who received an efavirenz-containing regimen had a 73% chance of suppression compared to 53% for those on nevirapine and 66% for those on abacavir. There's increasing data now to suggest that regimens containing efavirenz are superior to those containing protease inhibitors in terms of breakthrough and long-term suppression. And this would be one of the first studies to show a difference between efavirenz and nevirapine in patients with HIV disease. So if you have someone who's been on a protease-based regimen, has broken through, your best bet for a change would be to a regimen containing efavirenz rather than abacavir or nevirapine. Speaking of nevirapine, there was an interesting article in the New England Journal of Medicine that looked at what happened to patients who were put on nevirapine containing HAART after they'd received nevirapine to prevent transmission from mother to baby. This occurred in Africa, where women were enrolled in a trial to receive either nevirapine or placebo to look at how HIV was transmitted to the child. If a mother had had nevirapine in the prior 6 months before starting her HAART therapy, her chance of a breakthrough was 18%, as compared to 5% for those who had had the placebo wing of the study. Nevirapine resistance occurs quickly. One dose appears to be enough to account for it, and given its toxicities and relative lack of efficacy compared to efavirenz in the study just mentioned, I think nevirapine, at least in the United States, is probably becoming a drug of historical interest. Nevirapine is, however, effective in preventing transmission from mother to baby. Unfortunately, adding AZT does not increase efficacy, as pointed out in a recent CID article. What to do for patients in resource-limited areas like Africa to prevent the transmission of HIV from mother to baby is still a huge problem. And in the study that was published in CID, a whopping 23% of babies still acquired HIV and died despite nevirapine and AZT therapy, compared to 23% with the nevirapine alone. Better than no drug, but still a depressing amount of HIV passed from mother to baby. Tuberculosis, as of 2007, does remain uncommon in the West. Is it worth screening people at risk for reactivation of TB in areas of low endemicity? Probably yes, especially in the HIV population. If you have HIV and you're PPD positive, you have a 20-fold higher chance of developing active pulmonary tuberculosis and subsequently spreading it to others. In Switzerland, which is probably as homogeneous a population as you'd like, they looked at AIDS patients and testing of PPDs. In patients who were PPD positive who did not get prophylactic therapy, they had 1.6 per 100 person years of TB incidence, whereas nobody who received preventative therapy for tuberculosis developed active disease. They also found that if you got HAART and you suppressed your virus and improved your immune system, you had a marked decrease in your chance of developing active tuberculosis. They came to the conclusion that in a place like Switzerland, where there's very little tuberculosis, that it is worth checking patients with HIV for tuberculin skin test positivity and treating appropriately. Now, they did find, however, that a lot of their patients who went on to develop tuberculosis were from sub-Saharan Africa, exactly an area of low tuberculosis endemicity, but they still found that this held true for people who were from Switzerland itself. So if you have an AIDS patient, check a PPD. If they're PPD positive, give them prophylactic therapy. So you have E antigen positive hepatitis B. Bummer. Didn't get the vaccine as a kid. Now, there's therapy for that, which is adafovir. How efficacious is it long term? Well, there was a study that was published in Gastroenterology that looked at the results of patients who had been on adafovir for 5 years, and the results were pretty good. They found that about 3/4 of patients had improvement of their fibrosis and a decrease in their viral load, and that only about 20% of patients developed virologic resistance to the medication, which we've talked about in past podcasts. But I would say that long-term use up to 5 years is beneficial in patients with hepatitis B in about 3/4 of patients who can have a continued benefit both by biopsy, by serum transaminases, and by copies of virus in their blood. And that over time about 1/4 of them will become resistant to adafovir with fairly minimal amounts of toxicity. So this drug does have reasonable promise in the long-term treatment of e-antigen negative chronic hepatitis B. As I've said many times before, the reason we get to live into our 80s in the United States is good nutrition, flush toilets, and vaccines. However, despite vaccines, we still get occasional outbreaks of vaccine-preventable illness. Often these occur in populations of people who, for a variety of reasons, do not get vaccinated. Some are religious, some are just crazy. However, the source of these infections is often immigrants who come in with the disease. And it turns out that immigrants from other countries are less likely to be immune to these illnesses. One would think if you came from a third world country, you would have been exposed to mumps, measles, or rubella. But in a recent study in the Annals of Internal Medicine, they looked at adult immigrants in the United States and found that anywhere between 22 to 54% did not have immunity to mumps, measles, or rubella, and that immigrant populations are a good group of adults for whom you should consider targeted immunization programs. Another disease that immigrants are often not immunized against is tetanus, and all the tetanus I have seen have been people from countries where there's not routine tetanus immunization. Remember that if someone comes from another country, that they are probably not immune to many of the common childhood diseases and should probably get the vaccination series that we give to children. Which brings us to the question is, how good is the mumps part of the MMR? There have been outbreaks of mumps both in the United States and in the United Kingdom in the last year, which has led people to look at the efficacy of the vaccine. There was an article that looked at this that was published in Emerging Infectious Disease that tried to estimate the efficacy of the vaccine in England, and they found that as children got older, the vaccine efficacy wore off, and they estimated that greater than 20% of children between the ages of 11 and 12 did not have protective antibody against mumps, which is enough to allow the disease to perpetuate in the community. Some of the kids had 1 dose, some of the kids had 2 doses of the MMR, and those who had only 1 dose had less take than those who had 2 doses. But it would appear that the vaccine declines slowly over time, and by the time you're age 15 or so, you may no longer have mumps protection. Despite this, the CDC is not recommending repeat vaccination for people born after 1957, to judge from their website, as long as they've had 2 doses of the MMR in the past. For those of you planning on going on vacation this year, I'd like to point out that syphilis is increasing across the world. The biggest outbreak going on right now is in China, where they've had an annual increase of 72%, going from 0.2 cases per 100,000 up to 6.5 cases per 100,000 in 1999 and continuing to rise. Other places that are showing an increase in syphilis include the United Kingdom, Ireland, and the old Russian Federation states, as well as the United States, although the rates in the U.S. are not as high as those in China. The people at biggest risk for developing syphilis are female sex workers, drug users, and men who have sex with men. So when you're traveling to another country, just remember that many things are on the increase in the world. Syphilis is on the list. Increased syphilis rates also tend to correlate with increased HIV transmission, so one would expect to see HIV increasing in these areas as well. Economic freedom in China seems to be associated with sexual freedom as well, and subsequent increase in sexually transmitted diseases. I'll just mention in passing an epidemiologic report that suggested that men who had gonorrhea had twice the rates of bladder cancer as men who didn't have gonorrhea. I'm not sure if I believe this, but it's an interesting association, and they postulate that the inflammation and decreased emptying from gonorrhea increases the cancer rates. I don't know how a short infection could increase the rates of bladder cancer, and I would bet this turns out to be a spurious report, but you'll probably hear about it from other places. Moving on to another sexually transmitted disease, let's talk about trichomonas. The amazing thing about trichomonas is how infrequently people look for it. However, it is not an uncommon STD in women, and this study addressed how often men are infected with trichomonas. They found women who had trichomonas, and they looked at their male partners. They found trichomonas in 71% of male partners, and they found it was asymptomatic in 77% of male partners. So the vast majority of men have trichomonas if their female partner does, and they are asymptomatic for it, proving that they would be a good reservoir for recurrent infections. Also, 10% of the time there was a concomitant sexually transmitted disease with the trichomonas. The amazing thing, as I said, is the epidemiology of trichomonas, where they estimate that there are 250,000 visits to physicians every year for symptoms related to trichomonas, but only 45% of the time do physicians actually perform a microscopic examination to look for the presence of trichomonas. It is a disease that has more prevalence than it should and is looked for and treated less often than it should. But remember, when you treat a female for trichomonas, their partner probably has it as well. The other curious thing in this study is that there was no relationship between condom use and the prevention of trichomonas, nor the number of partners, nor the frequency of intercourse. It would almost appear from this study that one episode of intercourse, with or without a condom, would suffice to acquire trichomonas. I overstate here, but this appears to be a fairly infectious disease. Group A strep invasive disease remains a horrible illness that kills people fairly rapidly. There was a study that looked at prospective population-based surveillance of Group A strep in Ontario and found a total of 62 patients who had invasive Group A strep disease. They went to the ICU and had multi-organ system failure, and many of the patients died. Now, the interesting thing about this study is that while 40% died, they found no independent analysis that suggested that the use of IVIG or clindamycin was associated with increased survival. Now, the only study that suggests that Group A strep, necrotizing fasciitis, and toxic shock syndrome is beneficial when treated with IVIG was published in the CID about 5 years ago and did not reach clinical significance. And the use of clindamycin is based on animal studies, primarily where if you interfere with toxin production, you get better outcomes with Group A strep disease. Now, they only had 62 patients, and they found that the younger you were, the less sick you were, the more likely you were to survive. Not unsurprising there. But it is interesting that they found neither the use of IVG, surgical intervention, or clindamycin to be associated with survival. This is probably due to A, they don't work, or B, 62 patients hardly has in a non-randomized trial, has any form of statistical significance. Haemophilus influenza has long been associated with exacerbations of COPD and pneumonia, especially in patients with underlying lung disease. Is it always Haemophilus influenza? Well, there was an interesting study in CID that looked at patients with Haemophilus influenza, and they thought, these strains look funny. So they looked at them more carefully, and they found that in the sputum of 490 strains that appeared to be Haemophilus influenza, that 39% of the sputum specimens and 27% of the nasopharyngeal specimens were actually Haemophilus hemolyticus, and that the new acquisition of Haemophilus hemolyticus was not associated with exacerbations of COPD. On the other hand, if they had a new acquisition of Haemophilus influenza, this was associated with an exacerbation of COPD. Why do I mention this? Well, you need to ask your lab whether or not that they are looking to see if Haemophilus strains in the sputum are actually Haemophilus influenza or Haemophilus hemolyticus, because if it's the hemolyticus you're isolating, it may not be the pathogen at hand. Or perhaps I should say the pathogen at lung. Now, I don't know as I do this podcast what the standard is of the bronchoscopists in the hospitals in which I practice, but there was a study that looked at placebo versus azithromycin versus cefepime in patients receiving bronchoscopy. They looked at 930 patients who underwent a bronchoscopic biopsy in Japan, and they were randomly assigned either Zithro, cefkapine, or no antibiotics. Hope I'm pronouncing that right. I've never heard of cefkapine. Sounds like I'm stuttering, doesn't it? The only patients who developed pneumonia were those who had an abnormal bronchoscopy. So that's the subgroup that would probably benefit from prophylaxis. Of these pneumonias, 60% occurred in the no treatment group, 26.7% occurred in the cefkapine group, and 13.3% occurred in the azithromycin group. Now, what's the total number of patients with pneumonia? Well, it was 9 of 310 patients who received placebo, or about 3%. So patients with abnormal bronchoscopies who don't take antibiotics have about a 3% chance of developing pneumonia. Not a major source of pulmonary morbidity, but an important one nonetheless. Means are beneficial, even if no other reason, to put the tracking device under the skin. Those diodes are important for the government to keep track of where you are going. But also, the influenza vaccine appears to decrease mortality in patients with community-acquired pneumonia. This study looked at a database of 17,000 patients. And they found about 1,600 patients who had a vaccine for influenza and compared them with unvaccinated individuals and found that they were less likely to die of any cause by about 30%. That's pretty good. And this was held true even if they adjusted for comorbid illnesses and pneumococcal vaccine. The mantra remains the same. Get your damn influenza vaccine or die, die, die. On the Pneumonia Severity Index and other podcasts and pointed out how it can be used to predict who needs to be hospitalized for pneumonia. This was validated yet again in a study published in CID that was done in multiple ERs in France and Europe. They found that if patients were treated with type 1 or 2 by the Pneumonia Severity Index as an outpatient, they did fine and did not have increased mortality. In fact, ERs that used the Pneumonia Severity Index were more likely to have less mortality than ERs that did not routinely use the Pneumonia Severity Index. So you can use the Pneumonia Severity Index to risk stratify your patient, and if they're a type 1 or 2, they can safely be sent home without having, of course, to be admitted to the hospital. Although in the United States, not unfrequently, people are admitted not because of the severity of their pneumonia, but because of social things, such as they have no one to take care of them. The Pneumonia Severity Index is widely available in many places, including, of course, the Persiflager's Annotated Compendium of Infectious Disease Facts, Dogma, and Opinion. Legionellosis can occur in 2 forms, 1 in epidemic outbreaks, and 2 sporadic forms. There was an article that was published this month that looked at the 2, and they compared both community-acquired sporadic cases, 138, versus 113 outbreak cases in Spain. And they found the following things were associated with sporadic cases. More likely to be male, no surprise. Have more underlying lung disease, no surprise. To have immunosuppression, no surprise. And a surprise to me at least, they were more likely to have HIV. The sporadic cases were also more likely to have a delay in diagnosis, probably because people were not suspecting it, and to have a worser outcome. But these are the compare and contrast the sporadic versus the epidemic forms of legionellosis. Now, compare and contrast Moby Dick and Huckleberry Finn. Modern medical motto: no good deed goes unpunished. There's a case in the nephrology literature of a patient treated with inhaled tobramycin for chronic Pseudomonas colonization, and they got acute renal failure from their inhaled Tobra. That's just a beware note. There was a meta-analysis published in the Mayo Clinics where they looked at all the studies that compared the use of fluoroquinolones versus beta-lactams for the treatment of soft tissue infections and found them to be basically the same in efficacy, and found no advantage of using quinolones in soft tissue infections compared to with beta-lactams. I, of course, find this a little mind-boggling in that I'm an old geezer from the last century. I always use beta-lactams first for soft tissue infections. They're staph and strep, and nothing kills staph and strep with the exception of MRSA, like a beta-lactam. Now, the rule of thumb is that most drugs work most of the time in most patients if they don't have a life-threatening infection, and you would expect soft tissue infections to respond pretty much the same to any antibiotic you give them. I would bet, though I'd have to go back and look, that most of these studies were sponsored by quinolone manufacturers, leading to a little, if unrecognized, bias in favor of quinolones. I still think cephalexin, good as anything for an acute cellulitis if you're not worried about MRSA. Back in the Middle Ages, people worried about demon possession, and then for most of my medical career, the equivalent was Pseudomonas. Beware of Pseudomonas. Pseudomonads are bad enough, but there are other multiply resistant organisms that are becoming an increasing headache in hospitals. MRSA is one, and another is Acinetobacter. And one of the problems with Acinetobacter is it can become basically resistant to every antibiotic except polymyxin, which is not a benign drug. Does it make a difference? Yeah. There was a study that looked at the consequences of being infected with a multiply resistant Acinetobacter and found that it was associated with a longer hospital stay, a longer ICU stay, and probably an increased mortality. The patients with multiply resistant Acinetobacter infections had a 26% mortality compared to 18% of those with susceptible organisms. However, by various statistical manipulations, it was concluded that the mortality was not statistically significant in this study. However, generally speaking, if you can't kill a bug, it will kill your patient. So although not statistically significant, it makes at least some biological sense that if you have a resistant Acinetobacter, you're going to do badly by most criteria. Or is it criterium? Or criterias? I don't know the plural anymore. Posaconazole will be released soon. Its raison d'etre, you like my French accent there, is probably the treatment of mucor, but it would appear to be moderately effective in invasive aspergillus in immunocompetent patients. In a study that was published in CID this month, they looked at the treatment of invasive aspergillus with patients who received posaconazole 800 milligrams a day compared to external control cases, and they found that about 42% of patients responded to posaconazole, which isn't bad for an antifungal in a bad host. So our armamentarium for killing aspergillus is increasing. This century has seen an outbreak of Cryptococcus neoformans in Vancouver Island up in British Columbia, about 400 miles north of where I practice. And this has been well described, and there are 3 articles in Emerging Infectious Diseases this month about the Cryptococcus found in the Pacific Northwest. The first is that there was a reported case of someone from Denmark who was visiting Vancouver and got Cryptococcus. Bummer. The second is it seems to be at the moment reasonably isolated to Vancouver Island, and that profiles of specimens found in Oregon, BC, and Washington are different. And even though the environment is the same, so far it appears that Cryptococcus gaudae is primarily found in the island of Vancouver and not in off-island areas, though I bet you nickel that's going to change. Part of the change in Cryptococcus has been credited to global warming and a change in the local environment that has promoted the growth of Cryptococcus. The other thing of interest is how this is dispersed. It would appear that from their studies in a third article published this month, that Cryptococcus was frequently isolated in the wheel wells of vehicles on Vancouver Island and also found in footwear. So people who are hiking through these beautiful islands and driving through them are probably helping to disperse the Cryptococcus throughout the area. They also found it in wood chips and products that are used for park landscaping. So there's a number of methods besides the winds that are probably going to be associated with the spread of Cryptococcus from Vancouver, British Columbia. Certainly it's a beautiful place to go and hike and play, and I'd highly recommend it. Just to make sure that when you go to Vancouver Island, you take a deep breath and you don't inhale. Work for Clinton, work for me. The standard for bacterial empyema is probably a VATS procedure, and urokinase has become passé in the treatment of that infection. However, there's an interesting article where they compared standard therapy versus urokinase for tuberculous pleural effusions, albeit it was a small number of patients who were studied, to a grand total of 29. Half of them got intrapleural urokinase and the other half did not. And those who got the urokinase had less residual pleural thickening, and it was suggested that urokinase may be of benefit in the treatment of tuberculous pleural effusions. Now, this study was done in Spain, and I doubt we'll ever make the diagnosis fast enough in the United States where this will become of clinical importance. When I think salmonella, I think turtles, snakes, other reptiles. However, the New England Journal of Medicine published an article where there was an outbreak of Salmonella enteritica, serotype typhimurium, that were all obtained from rodents. These were pet hamsters and mice, and the salmonella in question was resistant to ampicillin, chloramphenicol, streptomycin, sulfamoxazole, and tetracycline. They had 13 pet stores that were associated with this outbreak of resistant salmonella in children, of which there were a total of 28 cases identified. How to prevent it? I think it's important before bringing any pet home to put it in the autoclave for half an hour. That will be a sure way to eradicate any salmonella and provide a tasty meal for the family. When I was a kid, I thought you got salmonella from eating salmon. I, of course, was wrong. But you can get stuff from eating salmon. The big one is the fish tapeworm, Diphyllobothrum latum, and there have now been outbreaks of this associated with salmon aquaculture, i.e. growing salmon on farms for consumption. Raw salmon may very well, even if coming from a farm, be infested with the fish tapeworm, and it can be passed on to humans. I do like my salmon on the rare side, opposed to hamster and mouse, which I've always preferred well done with a little light garlic sauce. And that's it for this month. I will point out 2 articles published in Emerging Infectious Diseases available online. One is Infections Associated with Wild Animals and Ecotourism. The other with Infections After Natural Disasters, and the fact that the dead bodies that are floating around after a natural disaster are not the source of outbreaks, but rather it's usually shifts in populations to areas with poor water and other hygiene. So let's give a big yippee-skippy for the end of this podcast. The Persiflagers podcast, a review of the infectious disease literature, this one covering January 1st through 15th, 2007. Brought to you by Pusware LLC, the publisher of the Persiflagers Annotated Compendium of Infectious Disease Facts, Dogma, and Opinion, your uber-hyperlinked electronic guide to infectious diseases, available at Pusware.com. Remember, CME accredited. Take the online quiz now and get a half an hour of free CME, free, thanks to Legacy Health System. If you like this nonsense, try out my Quackcast at quackcast.com, where I sarcastically review the infinite stupidity that is alternative and complementary medicine. Bandwidth ain't free, so feel free to purchase the compendium and support this podcast. It's copyright under the Creative Commons license, creativecommons.org. The music is by my son when he's 12 years old, improvising on the guitar. He is one wicked guitar player now. For comments, feel free to email me at mcrislip@pusware.com. And as always, thank you very much for this most interesting consultation and allowing me to participate in the care of this most difficult and challenging case. I will continue to follow along with you. Thank you. In dictation, goodbye.